The ACC's Pinnacle Registry shows a rate of 57% for anticoagulation use in atrial fibrillation patients. Worse yet, using CHAD's risk score data of those AF patients on anticoagulation, there are low-risk patients who are on dual antiplatelet therapy, as well as high-risk patients on no anticoagulant at all. So one of the concerns, of course, is bleeding risk. And in JACC, an interesting commentary has been published, Shared Risk Factors for Anticoagulation in Non-Valvular Atrial Fibrillation, a dilemma in clinical decision-making. And I'd like to introduce you to the author who's with me, Dr. Michael H. Kim, who is MD and Professor of Medicine at Warren Alpert Medical School, Brown University, Providence, Rhode Island. Your comments in the paper talk about another paper, it's an analysis of Aristotle trial. Can we talk about that first, then we'll talk about your comments?
Oh, absolutely. The paper that I was asked to write an editorial on was written by Heilich and colleagues. And I think it's a very important paper because it really addresses one of the core issues related to anticoagulation of atrial fibrillation, and that is the bleeding outcomes. Now, I think there's no controversy that people realize that atrial fibrillation is a risk for stroke, and people need anticoagulation if they have risk factors. The problem is, it's the other side of the coin, namely the bleeding risk, that results in clinicians not prescribing appropriate therapy. So what this paper really addresses is the adverse bleeding outcomes within the Aristotle trial. And I think it's very important because it shows that in comparison to well-managed warfarin anticoagulation, there is a marked cardiovascular outcomes benefit in terms of the bleeding parameters in the Aristotle trial. And also, very importantly, there was a 50% mortality reduction in the first 30 days. And so I think this is very important data because it brings in the concept of shared risk factors. And I think that is a critical piece of this paper, is that when you think about anticoagulation in AF, you have to look at not just the efficacy part, prevention of stroke and thromboembolism, you have to look at the bleeding outcomes. And I think this should change the paradigm to looking more completely at, say, a preferred treatment target, and that treatment target being both stroke and bleeding.
Now, in the paper, you actually talk about, I think you said you call it a crossroads in therapy with a movement towards the novel oral anticoagulants. At this crossroads, at this point, what's your message?
Well, I think the message is that we have a lot of new therapies for atrial fibrillation, specifically for stroke prevention, in terms of the novel anticoagulants. Now, there are 3 of them currently approved. There will be more to come. Now, I think what this really is that we have other options for anticoagulation in AF patients. And you can argue that there's a lot of advantages and maybe these are better. And I think in a lot of ways they have a lot of advantages and may in fact be better. What I try to do in the editorial is that if you really look at all the subgroups of AF, and there's so much heterogeneity in AF, that there really is still 4 agents currently in the toolbox, and one of those is warfarin. And, warfarin's kind of been raked over the coals, so to speak, with the advent of all these novel anticoagulants. Right. And so that's kind of why I'm saying there's a crossroads. I mean, there's a whole host of factors you have to consider with anticoagulation of AF. And in my personal belief, do I think the novel anticoagulants are a better therapy for most patients? Yes, I do. But I don't think warfarin should be abandoned. And if you look at, for many of the reasons, warfarin is still a player in this therapeutic market. And I think you have to look at all factors related to stroke, efficacy, bleeding outcomes, but there are other outcomes, realistically speaking, as well. Is there are subgroups of data that, we still need more data on. Specifically patients with renal disease, warfarin may be the place for them. What about people where there's an economic consideration or there's more of a value or population health? If you look at the dollars, warfarin might still be a player there. Now, all this can change, if you have disruptors, and I mentioned kind of disruptors being, functional antidote for the novel anticoagulants. Improved pricing, God say a generic, for one of these novel anticoagulants. So I think this is an evolving field. But I think there's a lot of opportunity here to have a lot of tools in our toolbox for the benefit of our patients.
You've mentioned risk factors several times. CHADS or CHADS 2 VASC?
I think the CHADS VASC is probably a better way to go.
It's a little harder, it takes a few moments longer, but in Europe, they really have adopted it.
I think in the U.S., CHADS-2 is used more prominently, but I think we've all grown used to calculating CHADS VASC, and I've kind of steered my practice more toward CHADS VASC.
Very good.
And what it does do is it does lower the bar for anticoagulation. What do you do with the CHADS-2 patient of 1? Okay, I've often used CHADS VASC to help further stratify them, and if they have a higher CHADS VASC score, I'll push the anticoagulation issue, but anticoagulation is often a two-way street between the physician and the patient.
Right.
But I think what's most important is that a discussion be had as to all the risks, both for stroke and bleeding, and then come to a mutual decision between the patient and the provider. And, I think more information is always critical to making an informed decision on both parties.
Do you think by facing this challenge of shared risk factors and taking a different look at things that will maybe correct some of the errors along the way, where right now we have people who are at very low risk who are on dual antiplatelet therapy, patients at high risk who are on none whatsoever? There needs to be some balance in this, doesn't there?
I think there needs to be balance. Anticoagulation of AF is kind of a frustrating area because I think if you look in the atrial fibrillation space, pretty much one thing everyone agrees on is that anticoagulation is appropriate. But if you look at the ACC Pinnacle registry data that you quoted, even the cardiovascular specialists don't do a very good job. Now, why is that? Well, I think there's a multitude of reasons, and one of them is, the bleeding risk issue. The other one is, you can bring in cost, you can bring in a whole host of factors. But, I think paramount to this is medical education is key. But I don't think in many ways medical education is enough. And, there should be perhaps some performance measures related to anticoagulation of AF in appropriate patients. There are technologies that can yield that. There is a technology actually in atrial fibrillation map where you can combine anticoagulation rates, outcomes, hospitalizations, mortality, stroke rates, and put it out there for public consumption. Now, I'm not sure a lot of people want to see that, but I'm sure some parties want to see that. Specifically the public, maybe third-party payers, maybe managed care. But as we move toward population health, value-based care, accountable care, these are one of the things that you have to ask yourself, why not? But before you can actually do something like that, you actually have to have an information stream. And a lot of outcomes is going to data-driven science, and we need to have better ways to acquire that data. But if you actually had a performance measure for that, that would be a start. And other ways, as healthcare changes, is what really works best for clinicians is not necessarily medical education or CME programs. Sometimes you need a feedback loop, a very up-to-date and generally positive feedback loop that holds providers accountable. And I'm not going to be popular in saying this, but in the future to come, there might be some financial penalties tied to that. And I think if you take the combination of all this, including medical education, we can maybe move forward in terms of better therapies for our patients based on the evidence.
Now, there's a pair of papers we're talking about that are online before print, so they are available right now. For CardioSource World News, I'm Executive Editor Rick McGuire.